don't get better. I don't like
We just, you're just.
I It's a good idea.
Or use Starbucks or something.
And I'm only doing that for you guys because you guys are good students and you all are in good standing grade-wise, so I think you'll still learn, you'll still listen, you'll still pay attention, you'll learn the information. But I think that's the option we're going to be going for at this point. So stand by for method of delivery.
Unibomb.com.
Yeah.
My other two classes, I am proctoring a test for them,
Okay.
just so that you know where you guys stand.
It will go in.
Smile.
Thank you. Oh, I'm so excited. Yep. That's awesome.
So what we're learning is it's important stuff. They're more excited trying to give me this. It's important stuff, but it is heavy stuff. So that's my thought process. So be preparing for next week not to have this class on Monday and Wednesday. And then if for some reason you would want to go to lab next week, you can look at the times on the board and just sit in on somebody's lab, but we'll do it after the test. So you have that other option. All righty, so there you go. Woohoo! People are flabbergasted.
Freak out, man. Freak out.
Yeah.
Very good day.
And I'll be sitting in Denver, so.
Oh, boy.
Did you get this one?
Well, yeah.
I had an extra one.
Oh. So let's wrap up this kidney chapter. On slide 45. Can somebody get the front light for me, please? Thank you. So we've been talking about it. We know that the kidneys are filtering the urine. Once it gets through the whole nephron, then we have urine, and we're eliminating unneeded substances and metabolic waste, and we're pushing about 47 gallons of fluid through. We looked at the glomerulus. We know it's for filtration. So the kidneys always have to have that pressure behind them. We call that glomerular filtration rate. So that's that whole, in order to have flow, we need to have pressure situation. So the body has to have that constant blood pressure. We have to keep up our volume so we can have our pressures going. And this allows us to be able to push the blood out to other tissues and deliver the oxygen and the nutrients. So water is a key part of keeping that pressure up, and that's the blood pressure that we're trying to keep up. So we have to keep that pressure at a fairly constant rate. Glomerular filtration rate is the volume of filtrate formed every minute by the kidneys, so 1.2 liters, we talked about that. And we have lots of different things that allow that to happen. The surface area, so we have lots and lots of nephrons. We have all those big capillary beds in there. They're going to be permeable, so we can allow that. And we have to have that pressure pushing all that. Then we go into, did we do this part yet? Yes. Okay. So we talked about how we control that intrinsic by vasoconstriction and dilation. We know that. And then we're monitoring what's going on in the tubes. And by tubes, the PCT, proximal convoluted tubule, the leukopenal, the distal tubule. And then extrinsically is that whole hormonal thing that we're talking about, the renin-angiotensin situation. So autoregulation, as long as we're between 80 and 180, we have enough pressure to push things through. Once we drop below 80, that's when we get into that extrinsic, and we get into the whole idea of all 5 of those things we talked about. The whole idea is always to keep our volumes up so we can have fluids and blood pressure so we can do all that filtration stuff we need to do. We're going to reabsorb things in the tubules. So we looked at water going out on the down and solids moving out on the ascending. And we always have to have that osmotic and hydrostatic pressure balancing that flow out. One's going to push out, one's going to push in, just like we talked about with the cells. So we're still in the cells, we're just in the cells of the kidneys. And then sodium being one of the most important things that we're always making sure we have track of, because wherever sodium goes, water goes. And then I I think we talked about formation and concentration. So what we're doing is we're putting all that fluid through the nephron. Blood comes in under high pressure, under that afferent arteriole, goes into the glomerulus, we filter it, and it's called filtrate. From that point, then we're reabsorbing it in PCT, and then we're fine-tuning it. And we're going to deal with the concentration of urine. If we like everything that's happening, we're just going to pass it on out and nothing happens. Or it's going to be concentrated if we're holding on to fluids, and then we're just going to pee off the waste stuff. Or if we're pushing off fluids, it's going to be dilute because there's going to be more water in it. So that's the job of the nephron, is to regulate the concentration, filtration, and then regulating that concentration of urine. So what happens if we get too much fluids in there? That's not a good thing. Too much volume means too much pressure, and that's not a good thing. If we have too much pressure, our blood pressure goes up, and that becomes dangerous, and it's hard on the vessels, and it's hard on the organs. So if we get too much volume, we have to push that off, and how we do that is through a diuretic. So water pill is what people call it a lot of times. A diuretic increases urine output. What do we drink that we know is a diuretic? What do we consume?
Coffee.
Coffee, tea, soda. Those are natural diuretics. Beer, yeah. Those are natural diuretics. They push fluids off, right? So diuretics are chemicals that increase urine output, and it has a substance, and has substances that are not reabsorbed. So alcohol, we know, is a diuretic, but the main reason alcohol is a diuretic is because it blocks ADH. So even if we want to hold on to fluids, it says, or if we want to hold on to them, or if we want to push them off, we can't, because alcohol blocks ADH. And ADH, remember, antidiuretic hormone, says do not go to the bathroom. So it comes on board, you're peeing off, losing volumes, losing fluids. And ADH says we need to get on board and say stop that. Alcohol says no, we're blocking you, you can't get out and send that message. So two reasons why alcohol pushes off fluids. One, volumes in, volumes out. And two is it blocks ADH, so that message can't get through to say hold on to fluids. Some diuretics inhibit sodium reabsorption. So if you can't hold on to sodium, you're going to pass it out. And so that's the mechanism behind it. Wherever sodium goes, water goes. So if you can't hold on to it, the diuretic block absorption of sodium, so it stays in the tubules, and you're going to pass it out. And if sodium is going out, water follows it, and it comes out. So that's how diuretics work, is they're going to block ADH, or they're going to block that sodium. Sodium's going out, so water's going right on out with it. And so coffee, tea, sodas, blood pressure medications act as diuretics. Congestive heart failure medications act as diuretics. So we're trying to maintain, and we're trying to keep your volumes where they need to be. If we get too much volume, we get puffy. And we get too much puffiness, we get edema, and that's bad for a lot of situations.
Got a mess in there.
Got a mess in there, right. So diseases, now we're moving, we're getting out of the water regulation. We have to make sure we're maintaining water pressures, and then we got to get out and maintain homeostasis. So what happens if things go even worse? Then we move into renal diseases. So in chronic renal disease, the glomerular filtration rate gets less than 60 millimeters per minute for at least 3 months. So something might come along, you might get an infection, you might have decreased output, but it has to be prolonged over a period of 3 months. So sometimes things happen, you get it back under control, and volumes go back up again, and your filtration rate is up in that 180 to 80 range again. If it gets below 60 for 3 months, that's when you move into the category of renal disease. And it sneaks up on people. It doesn't just like happen, all of a sudden you have renal disease. It's a slow progression, often associated with diabetes. So it's a gradual buildup over time. And the filtration gradually decreases. So it doesn't just all of a sudden you start having urine decreased output. It slowly works up to that usually. And when that happens, filtration decreases, and if we're not filtering things, things start backing up and accumulating in our system, and one of those things is nitrogen that's backing up. We see this in diabetes and hypertension. Too much blood pressure, pushing, wearing out the nephrons, and diabetes, just taxing the system in all kinds of ways. So those are the two main things that'll push you into chronic renal disease. Then we move into renal failure. Things are going horribly wrong. So now we're less than 15%. Glomerular filtration rate is less than 15. So you're hardly filtering anything at all. And filtration almost ceases completely. Everything's backing up. Ions, waste is building up. Blood and pH balances are getting out of whack. And so then you have to go on to dialysis. So when you're on dialysis, your kidneys are practically not working at all, less than 15%. So you go from 60 down to 15. So you still have a pretty big range in there when you're in chronic renal disease, from 60 down to 15. Once we hit 15, then you're in failure. And that's when you go on dialysis. So what are we putting through blood? So it's called hemodialysis. And this is artificial filtration. We're cleansing your blood. So it goes out of your body, goes into the machine, and this machine filters it and cleanses it for you. The wastes are cleared out. And then we add back in the good stuff that we need. Volumes come back in. And then glucose comes back in. Anything that we need comes back in. And then that machine does the job of the kidneys for you. So that's why once you're on it, you're staying on it because your rate is so low at that point. It might be once a week in the beginning. You might have it twice a week, maybe then you go for 3 times, and then it's going to get more and more frequent for longer and longer periods. But once you go on it, we were talking about that. Her patient didn't want to go on dialysis because she felt like that was kind of like succumbing. And once you go on, you're stuck on it. Well, yeah, but you might stay on dialysis for a really long time. You might be on it for many, many years. Or it might be a really short-term thing, and it's too much for your system, and you are overcome by whatever you need. All right, questions over diseases, filtrations? Yes?
Okay, so is dialysis infusion? Is that what that is? Or is that totally different? I have patients that come in for infusion, and they're cancer patients.
Okay,
What
so
are they doing there?
yes and no. So in dialysis, you're filtering, you're cleansing the blood. Not everybody who has an infusion is getting filtered and cleansed, but the final stage is you're putting it back in, so you're getting an infusion process. So dialysis involves the whole process of filtration, cleansing, and then you put it back in. That's the infusion part. And some people can just have infusion, where their kidneys are still working okay, but they need a boost.
Okay, that's the one, okay.
Yeah, so it just depends on what the condition is, how far along in the process you are. Yeah, so that's kind of a way to boost your system a little bit when it's struggling.
Okay.
Yeah. So like, what are they coming in for? Is that a chemotherapy?
Yeah.
Yeah. Yeah, so their systems are taxed, and then they need some help
Okay.
boosting back up.
Thank you.
All right, 10 more slides and we're done with this chapter. So properties of urine. We finally have gotten to that point. It's passing out the collecting duct, and now we have urine. We know urine is clear to pale to yellow. What gives it the color is urochrome. So, and again, it's the concentration or dilution. The more water is in it, the more dilute it's going to be, so it's going to be pale. Or when you get up in the morning, you haven't gone for however long you've been sleeping, so it's much more concentrated because you haven't passed anything out. So depending on where you are in the process. Abnormal colors can indicate blood. If there's red in there, if it's kind of a greenish tint, bile. Drugs can certainly change the color. Foods can certainly change the color of urine. What's the one vegetable? Asparagus. Turns your pea green.
Oh.
Yeah. Green beer around St. Patrick's Day certainly can do that. So foods can change it, just like with your stool, foods can change that too. Beets are the people get afraid of. If you eat beets have that rich red color, and it'll show up in your stool. And people are like, oh my gosh, I have blood in my stool. And you're like, well, what have you been eating? It doesn't take much. bacrites to change the color. And it does look like there's blood in the stool, so people get really upset about that sometimes. They're like, okay, have you done anything? You know, another thing that does that is frosting on cake, because they put those intense dyes in there. And sometimes there's weird colors, like there's black frosting in that, and it has a color base in it. And sometimes that will show up. I'll get panicky calls like, oh my gosh, my son, blah, blah, blah. It's like, okay, well, what have you been doing lately? Are they eating Play-Doh? You know, what are they eating?
Just on the weekends.
And so, frosting and bakery cakes will do that. So, you know, think about what have you been doing before you panic and think there's blood in your urine or your stool. Yes.
Last week, my boyfriend's 5-year-old son had went through that. We had assumed that maybe he got sick from diarrhea because he was going creaking, playing hard, whatever. He'd had it for a couple of days, and then Sunday night he gets rushed to Children's because there's a red color to his bowel movement, and parents are just absolute panic. But they get to the office, takes forever for somebody to come back and see him. The doctor comes and smells the sample, so they're freaking out even worse. Like, oh my God, it's terrible.
What did you eat?
And all it was red dye from Gatorade.
From Gatorade, yep.
And
It's the red color that causes trouble. Yeah. So, and then of course, like if you have really intense diarrhea, if you have food poisoning kind of thing, and it's just coming out, then you'll have blood in the stool then, but that's just because the lining is so irritated. So that's a normal thing too. And you may need to go to the doctor if you're at that point and get some kind of antibiotic, because that's usually an E. coli sort of thing. And so there can be blood in there, but it might be like a short-term irritation kind of thing. And so if you get a really bad case of food poisoning, it just keeps coming out, and then the lining, this stratified squamous cells are like, we do not like this, and they're going to start shedding, and then you'll start getting that situation. So, yeah, and that's in the digestive chapter. But colors, so look at your foods, think about what have you been eating. When in doubt, it's always good to go to the doctor and get it checked out, just in case it's something serious. Cloudy, we know that's UTIs, because what's showing up in the urine that's making it cloudy? What cells are showing up in there? White blood cells. White blood cells, you have a lot of infection going on, so they're just spilling out. The smell of urine, we all know what that smells like, it has the ammonia odor to it. The longer it sits, that's when the smell comes on, because it's bacteria, it's decomposing. Fruity urine, diabetics. Has anybody ever encountered this? Has anybody ever been around a person who has diabetes? It is very fruity smelling. Sometimes they'll say it smells like, yeah, their breath is fruity and the urine is fruity. And sometimes people say maple syrupy. It smells like maple syrup. So that's an indication. If it smells fruity, urine or their breath, that's an indication of there's diabetes, because there's so much sugar going out, and it literally smells fruity. pH slightly acidic at 6, and we talked about specific gravity in lab. It's the water plus the stuff. We have normal stuff in there, and normal values 1.001 to 1.035. The higher we get, the more stuff is in there, or it could be low and there's not enough stuff in there. So normal values for the weight of urine. Urine's mostly water and 5% solids. It's derived from, urea is derived from the normal breakdown of our amino acids, so this is the normal byproduct that happens. We have concentrations of protein, white blood cells, bile, glucose. If that is showing up in the urine, then that's not a normal thing. We don't want to see that. So in lab, we saw protein, and we saw glucose show up in the 2 samples we did on the sticks. So that's a lab question. Specific gravity, usually a question, is it within that range? And then the other one is what showed up, protein and glucose showed up in our samples. So we'll match it up. We don't want to see those in there. All right, then we look at the anatomy of the bladder. So the bladder is roundish, and the 2 ureters come in the back, and then they come in, and we have they call it the trigon, where the 2 ureters come in, and then we're gonna drain out that urethra. So we have ureters coming down, draining into the backside of the bladder. And then, excuse me, the urine has to get out. And it's gonna go out through the urethra in both males and females. In males, it comes down the extent of the penis and out. In females, it's only 1.5 inches, it just comes out the urethra. So the anatomy of that makes it very easy for females to get UTIs, urinary tract infections, because it only has to go up that little 1.5-inch canal, and then you're in this dark, moist, warm environment, perfect breeding ground for bacteria. And that proximity of the anus to the urethra, very close, so it's easy to carry bacteria forwards. So that's why girls tend to get UTIs easier than men. So urine comes down the kidneys, down the ureters, into the bladder, and out the urethra. Remember, the bladder is made up of transitional epithelial cells. That's the kind that allows it to expand. So that's the one place where we see that. In the male, then it's going to come out. This is the prostate right here. So that's the prostate gland. And then it comes out the penis. So in the male, urine comes out the penis, out the urethra. And also semen is going to come out that same pathway. Never at the same time. There's 2 different mechanisms going on there. But it has a dual process in men. So that's what we're looking at here. But this is why when men get prostatitis, inflammation of the prostate, and they get that feeling of they can't go, they gotta pee, but they can't go. It's the prostate here, and the urethra exits right down the middle of it. So if that gets inflamed, the urethra comes down the middle. If it gets inflamed, it starts squeezing on it. That's why they feel like they can't go. So you get them on an antibiotic, it opens back up and they can go. And you can get that at any age, but it happens as you get older. Once you get into 40s, 50s, 60s, it becomes a more and more frequent problem. Yes.
I was gonna say, we had a patient one time when I worked in the surgical inpatient unit. We had a patient come in and we did a bladder scan. He was full. He was absolutely full. So, and he couldn't pee. So they assumed there was something wrong with his prostate, but we had to straight cap him, and I felt so bad because nothing was coming out. He was in so much pain on top of getting capped and everything, but his prostate was so like enlarged, the catheter couldn't go through. It was terrible. It was the most horrible thing I've ever done to a
Oh my
patient.
gosh. And so finally, you were able to cap?
Yeah, someone, I can't remember, we had to have somebody come in from the urinary, whatever.
Like a specialist?
Yeah, and do it, and with a different kind of catheter and stuff, it was.
Oh man, talk about agony. Yeah, so women have a lot of difficulties, but when it goes wrong for a male, it goes really wrong.
wrong.
Yeah, we go through childbirth, which equals it out though.
Yeah.
Yeah. Oh yeah, that would be bad. So when you cap the female, no big deal, 1.5 inches. When you cap the male, there's a long ways up there. Plus, anytime you're introducing something from the outside, there's risk of infection, and you have this whole channel for it to get infected in men. So yeah, it's just a delicate situation. More on that in the reproductive chapter. So the ureters drain the kidneys down to the bladder, the long tubes, and location helps prevent backflow. So we have a long channel to come down. So it leaves the kidneys, and gravity is pushing it down, and peristalsis is pushing it down, so it's not going to back up into the kidney, and then it's going to go to the bladder and out to your urethra. Kidney stones, we've talked about those. Those are called calculi. It can be calcium, magnesium, uric acid salts that are crystallizing in there, and they form the stones, and they form in the renal pelvis, and then they got to get out. So they can sit in the renal pelvis. They may never move. But then they go down the ureters, and they're very thin, and they're very flat, and the stones are crystallized, so they have jaggedy edges, so this is very painful when those are moving down. Things that can predispose are diets high in calcium, an alkaline diet, infection, frequent urinary tract infections can lead to that, and holding your urine can back up into the kidneys, and it can cause that to happen. And then we talked about lithotripsy being the ultrasound where you break it up. So they just they do a dye study, or however they're gonna diagnose it, and then you can see where it stops moving, and then you know the kidney stone is at that place, and then they'll just put the ultrasound machine on and just blast it. So that's called lithotripsy. And then you blast it into little tiny pieces, and then they can pass out. Sometimes that doesn't work, and you have to surgically remove them. Hopefully it doesn't go to that point, but it can get there sometimes. Very painful. Feels just like labor pains that don't go away. There's no break in between. That's what kidney stone feels like. The bladder is smooth and collapsible muscular sac. We have the urethras coming down into it, and the ureter exit, or the ureters come down, the urethra exits. So we call that the trigon, where those three things come together. The bladder is very stretchable. It's made up of transitional epithelium. And the urethra, what we've been talking about, a thin muscular tube. We have two sphincters there. The one is internal. That's automatic, that's involuntary. So when the bladder fills, then the internal sphincter automatically releases that. That's involuntary, we don't have control over that. What we do have control over, luckily, is the external sphincter, and that's the voluntary one. We can hold it until we can go, and then we release the sphincter, and then the urine passes. And this is what we lose control of. That's why we have incontinence, is the internal one's going to release anyways. The external one, it doesn't get as tight, so you do your Kegel exercises to keep things tight, and then it just gets loose. This is why you have leaking with like coughing, laughing, jumping, running kind of things, because when you do that sphincter loosens, and as it gets less tight, then you have dribble situations going on, or you just lose control altogether. So that's what incontinence is we're losing control over that external sphincter. So females 1.5 inches, males 6 to 8 inches, and male serves a dual purpose, carries urine and semen, and the prostate can cause problems for mating. So only men have prostates. Micturition is the act of emptying the bladder. 3 things have to happen. So the smooth muscle has to contract of the bladder. The internal has to release, and then we are in control of the external. So all 3 of those things happen when it's time to void or micturate. And distension of the bladder sends the signal to the brain. The receptors, those stretch receptors, go to the brain and say it's time to void the bladder. So stretch receptors, like in our lungs, we have them in our stomach when it says time to stop eating, you're full, and then in the bladder. And the last thing, incontinence. Incontinence, the inability to control voiding. Muscle weakness is the main reason we get that. Coughing, laughing, sneezing. Childbirth, a lot of pressure pushing down, so it weakens those muscles, then you strengthen them back up with your Kegel exercises. Emotional, people get scared. We've all seen that before on TV or whatever. We get scared, pee your pants kind of thing, because everything goes flat and everything dilates. So emotions can do that as well. And then urinary retention. The bladder is unable to expel urine, and that's a bad situation. So what we're talking about, you have to go up a catheter for whatever reason. It might be a prostate, it might be the bladder, and it gets inflamed and you can't release the fluid, so you have to cover it. And that's the end of the urinary chapter. So done with urinary, finally. Questions over any of the anatomy? That's mainly what's going to be on your lab test. So making sure you know all those different models that we looked at in the lab. And then on to fluids, because that really will be your name. And that's chapter 1. So what do we have left? We've got nutrition and health. I think we don't really need it in the summertime. Digestion, reproduction, then we have digestion and nutrition. Fluids. Okay, on to chapter 26. So a lot of this we talked about in the other chapters with fluid volumes, so we're just kind of repeating a lot of ideas. The fluids, electrolytes, and pH, water everywhere. So a lot of the pH stuff that we're going to do in the lab on Wednesday is found in this chapter. We've learned about the lungs, we've learned about the kidneys, and it's all about flow of air in the lungs, flow of fluid in the kidneys, and how we're going to buffer our system. The kidneys are going to buffer with the bicarbonate, HCO3, and the lungs are going to buffer with carbon dioxide. So we're going to talk a lot about the pH in this chapter. So homeostasis, cells depend on maintenance of fluids. We have to have fluids so we can keep our blood pressure up, we can have our volumes up, and everything stays in homeostasis. We have to have our fluids there. We have to have the electrolytes to make all kinds of things happen. And by electrolytes, we're talking about our salts, our sodium, potassium, chlorines, magnesiums. When we get into acids and bases, we're looking at what are we doing with strong acids and bases. So we know hydrogen is the ion that really pushes the pH scale, right? So we have things like hydrochloric acid in our body, sodium phosphates in our body, and those things are going to dissociate out. They're going to break into hydrogen and chlorine. And so then we have that strong hydrogen pushing things in the acidic direction. Or sodium sulfates are going to, or bicarbonates are going to dissociate out. And we have to regulate those electrolytes that are floating around in that fluid. So the pH is a big part of the fluid chapter because these two things go together. It's like the ocean and salt water. It's a solution. It looks like one thing, but we can separate those two things out. Same thing happens in our body. It's basically a saline solution, but we can separate those out, and the things we're separating out can really affect our pH and all the things going on in our body. So cells depend on physical and chemical homeostasis for their surroundings. The physical, maintaining boundaries, maintaining volumes, and then the chemical, what's going on with all of our ions in there. So water content. The body water is determined by many factors. Sex. Men are 60% water and females are about 50%. So males are a little heavier, they have more water. Age certainly is a factor. Infants are the dewiest people. They're fresh and watery. And then elderly are the least fluid people. They get dehydrated. So that's why we look less fresh, because we lose the water over time. Muscle holds more water, so again, men have more water in them because muscle holds more water. Typically men have more muscle because they have testosterone. Nothing sexist about that, just the chemistry behind it. Fat holds the least amount of water. Bone even holds more water than fat does. And women typically have more fat. So we have breast tissue, we have hip tissue, we have glutes.